Right. I think we're all on now. Apologies. We had a slight technical challenge. So apologies that you've been in the waiting room for a little while. But welcome to the British Society of Lifestyle Medicine webinar. And today we're really fortunate to have Dr. Seb Gray with us, who's going to talk to us about a lifestyle medicine approach to CYP asthma. And Seb is a paediatric consultant in Salisbury NHS Foundation Trust. And he is accredited by RCPCH with a specialist interest in respiratory medicine and high dependency care. And Seb's wife is also has a passion for lifestyle medicine, so which is how Seb got into it. And I, for one, am really, really interested in hearing about this because we know that asthma is really high in the UK at the moment, and we do have the second highest mortality rate for paediatric asthma in Europe, which when I heard that, I nearly fell off my chair because I think, it's something that we really, really need to tackle and definitely work well into. So I will pass you over to Seb and I'll ask you to pop any questions in the Q&A and then we'll come to you as we go at the end. So over to you, Seb. Thank you.
Perfect. Thank you very much, Rupa. I'm also the new co-chair of the Specialist Interest Group for Children and Young People Pediatrics at BSLM. So if there is anyone interested in helping develop and evolve lifestyle medicine approaches to any childhood condition, please do get in touch. But one of my passions is asthma, and I've learnt a new passion of lifestyle medicine from my wife, who's done the accreditation, now practicing, and looking over her shoulder. Oh, that looks interesting. That could apply to children. So hoping to improve and increase the amount of pediatric approaches that could happen with lifestyle medicine. But you've probably seen there's new asthma guidelines. If you've signed up to this, you're probably interested in asthma. At the end of November, there was this combined approach from NICE, SIGN, BTS. They used to produce individual guidelines, but now they've joined forces, which is fantastic. What's less fantastic is there's no mention whatsoever of any lifestyle factors in these guidelines. It's all about the drugs. And this is a talk where I will say lots of things about lifestyle approaches and different things, but actually inhalers are essential for the management of asthma. This isn't a talk to say this is an alternative approach. This is a complementary approach. But with lifestyle factors, there's the potential that we can prevent asthma from happening in the first place. We can have better control of asthma that's been diagnosed, and we can reverse potentially asthma being lifelong and hopefully speed up the process of children growing out of it. And we've produced some local guidelines aligned with the NICE guidelines to try and support the medication side of things. And this is really to focus on the other factors, focusing on the different pillars. This is a quick plug for the Ask About Asthma campaign that happens every year around September when asthma peaks. There's simple things that we can do. A written asthma action plan, a simple piece of paper, reduces your chance of being admitted into hospital fourfold. So it's really fantastic to be able to do that. Understand how to use the inhalers correctly. Less than three-quarters of children know how to actually use their inhalers, which is absolutely shocking. And that's probably why we have those awful outcomes that Rupa mentioned. So if we're prescribing medication, at least make sure we're prescribing medication to be used in an appropriate way. Having an asthma review every year is really important because, like I said, children hopefully will grow out of asthma and they don't need to carry medication if they don't need it. So it needs to be reviewed every year. But also, if they have an asthma attack that means they present to an emergency setting, that's an opportunity to review things. Is there something else we can do to optimize their management? And then I was delighted to see air quality come on as one of the other four focuses this year, because that is one of those harmful things that can have an impact. We'll talk about that in more detail later. But watch out for Ask About Asthma 2025 coming in September. So lifestyle medicine, I don't need to tell you this. It's the first time I've done a talk like this to an audience that will already know that lifestyle medicine is evidence-based clinical care that supports behavior change through person-centered techniques. It addresses the six pillars, which we'll go through one by one, to prevent, so stop asthma happening in the first place, manage, optimize treatment, give better quality of life, and reverse certain chronic conditions such as asthma. The most common childhood condition, 1 in 11 children have it, by promoting sustainable lifestyle changes. I'm going to keep this talk sticking to the lifestyle pillars: healthy eating, physical activity, minimizing harmful substances, healthy relationships, mental well-being, and restorative sleep. So I'm going to go through one by one how each of them interplays with asthma and what we can focus on and highlight to try and optimize the health of young people and adults. So healthy eating spans lots of things. And as a general rule, if you eat healthy, you'll be healthy. But there's many different aspects within asthma that play a big part. So fruits and vegetables in general are anti-inflammatory. They've got lots of antioxidants. Asthma is an inflammatory airway condition. And so if you have anti-inflammatory foods in your diet, lots of antioxidants, naturally you're going to have more benefits. And that's been proven. Whole grains really important as well. And when I think automatically of whole grains, I've got those advertising things in my head that automatically think of cereals, and they're full of sugar and additives, which aren't whole grains. What we want are whole oats, quinoa, bulgur wheat, brown rice, spelt, whole wheat, corn, even especially for children, popcorn. That's fantastic. The kids are going to much rather have popcorn as a snack than a packet of crisps, and it's going to be better for them. Vitamin D. Vitamin D has been associated in pregnancy with the risk of developing asthma. Low levels, you're more likely to develop wheeze and asthma as you grow up. Likewise, it's been linked with poorer asthma control and worsened symptoms if you've got low levels of vitamin D. There are other factors in play. We get vitamin D from the diet, but we also get it from sunlight. So children and adults are outside less, doing less outdoor activity. Their vitamin D levels are likely to be lower as well. So there's different factors in play. Antioxidants as well, specifically vitamin C, E, omega-3 fatty acids, they all play a part in protecting against inflammation, and they correlate from studies that you see enhanced lung function and reduced inflammation when there's high levels of antioxidants within the diet. And then you've got dietary fiber as well. So that maintains gut health. I'll talk in a bit about, everyone knows about the gut-brain axis, but there's also the gut-lung axis. And you get the short-chain fatty acid productions, the butyrates that protect against the dysbiosis and can prevent that gut-lung axis malfunction where you can develop more inflammation. And they have excellent anti-inflammatory effects. You'd have to be living under a rock if you haven't heard of ultra processed foods. Chris Van Tulleken's book, Ultra Processed People, is fantastic and a huge eye opener. There is a lot of evidence that ultra processed foods are bad for us. They create obesity, but they also create this low level inflammatory response within our gut lining from basically eating foods that weren't designed for human consumption. That low level of inflammation, again via the gut lung axis, can cause increase in asthma. I love this young youth activist movement, Bite Back, who go by the motto, fuel us, don't fool us. And they're really challenging society at the moment with the food industry, and particularly the fast food industry, to try and stop the younger generation being tricked in to ending up obese, ending up with increased inflammatory conditions and a completely distorted gut microbiome from having this inundation of advertising and junk food forced upon them. So in terms of what ultra processed is, I like to remind people about the NOVA classification, which is just a group 1 to 4. Group 1 is not processed at all or minimally processed, whole foods, gradually increasing with the more you preserve foods with herbs and fats, and then combine groups 1s and 2s for 3s. And then in group 4 is basically ultra processed food. And as a general rule, if you can't find ingredients in your kitchen cupboards at home, it's likely to be ultra processed. So when you're looking at the packages in the shops, which you will almost certainly do once you've read ultra processed people, then you will see ingredients that you don't recognize as being able to store at home. They're the ones that are properly ultra processed and will be not doing your microbiome any good by consuming. I love little data sets like this. If you scan QR codes, I'm happy to share slides after, but there's an individual company that's looked at food deserts, not food desserts, this is food deserts. This is where the yellow areas are where you cannot access fresh fruits and vegetables within a kilometre of where you live. Most of the research looks at urban areas. They're looking at high density population city areas where you still have food deserts. But actually, I live in Wiltshire where we're not population dense, we're massively spaced out, and there's huge areas of food deserts where you can't access cheap fresh fruit and vegetable, which means that you're going to go to the easy options. You're going to go to the fast foods, the convenience stores, the stuff that's not good for you, which then creates that low level of inflammation and increases the risk of developing asthma. It's particularly pertinent at the moment with the cost of living crisis. Again, because I live in Wiltshire, I've taken some local data here. This is to do with poverty. You can divide up the country into deciles based on the index of multiple deprivation. So here is the poorest 10%, here is the richest 10%. And this is what they spend their money on. 17.9% of the poorest 10%, so the poorest spend 17.9% of their disposable income on food and non-alcoholic drinks. That works out as £43.86. The richest spend a lower proportion of their disposable income, about 12% on food and drink, but that's 12% of 1399. So we're talking about £150 around that sort of level. So you've got a third for the household, a third less money to spend on fresh fruit and vegetable, healthy foods than you do if you're rich. And this was in 2021. £43.86 to feed a family for a week is not that much, particularly if you want to, feed them, eat the rainbow and eat lots of fresh fruit and vegetables. That was in 2021. Since then, the cost of food and drink has gone up by about 20%. It's not as simple as just saying, oh, why don't you eat more healthily? There are significant financial constraints, and that's why we're seeing lots of these widening health inequalities, which are really sad. If money wasn't an option, what can we suggest? Well, Mediterranean diet, I'm yet to see any lifestyle talk that doesn't talk about the Mediterranean diet as being beneficial, but it has been also shown to be beneficial for asthma. So this diet has lots of anti-inflammatory properties. It's rich in antioxidants. It's lots of fruits, vegetables, whole grains, healthy fats, olive oils. If you're adults, a bit of red wine. I'm not advocating for giving that to children currently at the moment, but all sorts of studies have showed the benefits. So adhering to Mediterranean diet, it decreases the risk of developing asthma in the first place. If you've got asthma, it improves the symptoms. They have better well-being scores if you adhere to the Mediterranean diet, and you have improved lung function. So overall, the Mediterranean diet is really helpful for managing asthma. Asthma and obesity are heavily linked. There's an increased prevalence of asthma in obese children. So obese children are 50% more likely to develop asthma or be diagnosed with asthma. And there is a differentiation because actually, if you're obese, you're much more likely to report breathlessness than if you're not. And so some of these young people will be misdiagnosed with asthma, and it's difficult to untangle the two because there is significant overlap. I think there's going to be a new condition with the asthma obesity phenotype because what's interesting is the management of asthma with someone who's got a normal body mass index compared to someone who's obese is very different. The asthma obesity phenotype does not respond in the same way to traditional pharmacological treatment in the form of inhaled corticosteroids. They are not as effective. Obesity in itself, you will see they will have levels that show or indicate chronic inflammation, both within the airway and within the bloodstream, which means that it's even more tricky to counteract that and balance that. But when we're treating asthma, we need to make every contact count, and we need to also tackle excess weight. And by targeting obesity, by improving and getting to a healthier weight, that improves asthma outcomes, both in quality of life, but also spirometry, lung function, and every other measure you can do. So asthma and obesity are not two distinct separate things that we need to tackle by two different teams. Holistically, we need to manage them both, and they will be beneficial to each other. I've mentioned a few times about the gut-lung axis. There is evidence that dysbiosis of the gut increases the risk of developing asthma. There's also benefits of augmenting that dysbiosis or improving the microbiome within the gut that can improve respiratory health. We've actually signed up to do a mini study with Simproof to see how palatable and what happens with known asthmatics by giving a period of Simproof to our young people with asthma. So watch this space. We'll keep you updated with how that goes. Naturally as well, by eating the rainbow, having those 30 plus points, potentially we can augment the microbiome in a natural way that will help. And there's some good resources being developed. David Bell is very enthusiastic if you've ever met him, but he's written some books designed for children called Belly Bugs, which are a fantastic way to introduce the gut microbiome to children and young people. And there was some chat on the school specialist interest group, WhatsApp group this morning, literally about resources about the microbiome. So there will be lots, I'm sure, coming out later. So we need people to increase their intake of fruits and vegetables. 5 a day is sort of moving more towards the 30 plus plant points, which I think is more inclusive. It includes the whole grains, the seeds, as well as the fruits and vegetables. So eating the rainbow, trying to get those 30 plus plant points with fruits, vegetables, whole grains. Healthy fats as well, trying to get those omega-3s in there, those anti-inflammatory, antioxidant properties. Limiting ultra processed foods to as much as possible. We don't want children to feel socially isolated by saying, well, you can't go to that party at McDonald's, and being the only one left out. But likewise, if we can change society so that they're not going to a party at McDonald's, that would be better. And then we're talking about asthma. So asthma can be triggered by all sorts of things, some of which might be foods. So working with individuals to find out what foods potentially make their symptoms worse and trying to limit those or avoid them as much as possible whilst giving a healthy diet. So one pillar down, we're now on to physical activity. And there's so many benefits of physical activity for asthma. It's been shown to reduce inflammation both in the airways and in the bloodstream. So FeNO, the fractional excretion of nitric oxide, that's now the first diagnostic test that we do for anyone with asthma. You measure how much nitric oxide is being excreted using a simple blowing device, which we can do from the age of 5 and up. It's been shown that by doing exercise in asthmatics, this number comes down. You reduce the inflammation within the airway by doing exercise. Likewise, blood tests have been done looking at cytokines. Th2 is the T helper cells 2. That's to do with allergy and asthma. They pump out cytokines like IL-5 and IL-4, which cause the inflammation. IL-10 is a bit like a policeman trying to control that and comes along and says, whoa, 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 calm down. Let's not get inflamed here. Let's keep everything calm. Exercise boosts this IL-10. It increases the number of policing IL-10s coming around, stopping that inflammation. So exercise within the airway reduces FeNO, and within the bloodstream boosts IL-10 to reduce that inflammation. It also increases endurance, so you're able to improve your respiratory function overall. The reduced inflammation, as I mentioned, improved lung capacity as well, and these are by objective measures using spirometry, and then muscle strengthening. So when you need that additional muscle strength, accessory muscles during an asthma exacerbation, they're going to be stronger and work more efficiently. Overall, cardiovascular fitness improves, and the heart and lungs are best friends and work closely together. The lungs are also very good friends with the brain. And so endorphins being released from exercise, the happy hormones, reducing stress, improving mood. Mood and stress play a big part in asthma, and so that's hugely beneficial. And then we've spoken about the gut as well, but there are metabolomic effects and benefits of doing exercise. You get enhanced butyrate production, which again stifles some of that inflammation, improves gut health, and you get reduced inflammation, which is always beneficial. And there's some suggestion that may balance out some of that unhealthy eating if you can exercise more. Ideally, we'd tackle all pillars equally, eat healthily and do lots of exercise to get overall benefits. But there is some evidence that by doing more exercise, you can counteract some of those negative impacts from that westernized diet. Also, I've mentioned a few times that pharmacological treatment is useful for asthma, and it really is. Exercise can improve the levels of that pharmacological treatment, how effective it can be. Inflammation is the result of oxidative stress. And by doing exercise with pharmacological treatments, you reduce the oxidative stress markers and you increase the antioxidant activity. So overall, you get less inflammation. The marker of inflammation, of oxidative stress that we see in the saliva, the MDA, malondialdehyde, that goes down after exercise. And that's whether you're obese or not. So in normal body mass index, young people and adults, by doing exercise, you still reduce the level of inflammation. So exercise isn't just being advocated for those who are overweight or obese. This is for all. Exercise is good. So why doesn't everyone do it? Well, lots of young people with asthma worry about doing exercise because of exercise-induced bronchoconstriction. Exercise-inducing asthma attack can be incredibly scary. And therefore, some people say, well, I'm just not going to do it. That can then result in this vicious cycle of a sedentary lifestyle, deconditioning, and then less and less going on. You get more deconditioned. You've got less reserves. Your muscles aren't as strong. You can endure less. Your cardiorespiratory fitness just goes down, and you end up with worse consequences, and it spirals. There's a fear of asthma attacks in the young people themselves, but also other people around them. parents can relay those fears. Likewise, schools, if they're not confident, can make sure that children and young people getting breathless if they've got asthma is a scary thing. Every child should be getting breathless for an hour every single day. We want asthmatic children to be doing enough exercise that they get breathless, but recognizing when they have asthma. Self-efficacy is the belief about their ability to be able to perform things. And there's really sad studies with children and young people with asthma feeling like they won't be able to achieve things in team sports, for examples. They're more likely to volunteer to go in goal rather than be the star striker. But some of the best footballers in the world, David Beckham, made me feel very old in clinic the other day when I mentioned David Beckham had asthma, and they didn't know who David Beckham was, which made me feel incredibly old. But there are some incredibly successful sports people who have asthma, and you'd never guess if their asthma is well controlled. The more exercise they do, the better their asthma control and likelihood of growing out of it will be. I mentioned before about obesity, and breathlessness in obesity is very, very common, particularly in the adolescent age group. The vast majority of this is caused by cardiopulmonary deconditioning rather than directly from asthma symptoms. However, there is a significant overlap, which makes it incredibly difficult to manage or advise as a blanket rule for everyone. In terms of gradually increasing fitness, it's really important to break that sedentary lifestyle. If a child has ended up becoming obese, they have ended up in a vicious cycle of having too many calories, not enough physical aerobic activity. And so that needs to be counterbalanced and reversed somehow, but gradually. There's lots of interconnecting health issues, and you need to promote healthy activities that work for that young person. There's a picture of a cricket player there. I wouldn't want to play cricket, but there's lots of other physical activities that I would like to do. It may be, particularly in our current adolescent group, they're very, there's lots that game. And so there's lots of virtual reality. There's lots of, Wii Sports has now progressed to Nintendo Switch. There's Just Dance. There's screen time. There's Pokemon Go, where you get out and about collecting Pokemon. You may need to adjust your beliefs and what you would ideally like them to do to gradually ease them into doing a bit more physical activity because it's going to be beneficial and you can always build on that. Lots of studies have been done looking at exercise. Pretty much all of them have been very, very low numbers, but all of them tend to show benefits for various different parameters. We've got studies showing improvements in VO2 max, quality of life, pulmonary rehabilitation, which is very commonly used in the adult world, has been shown to have positive outcomes, improving overall health in overweight or obese children, young people with asthma, less symptomatic days, reduced ventilation requirements, and less hyper-responsiveness of the bronchial, all with different programs that work. So you've got less twitchy airways, less symptoms, reduced ventilation requirements. It's all good stuff. So exercise is good. What's also good is stretching. Not really technically an exercise, but it actually does help. So it gives you better posture, which is important, particularly for exacerbations when you want to augment and maximize the use of those accessory muscles when you need it. So breathing with a good posture can really help. Also, you avoid muscle hypertonia and enhancing flexibility, which is important. Any stretching exercise should be relaxing and will therefore reduce anxiety. And it can really promote that controlled breathing. So if you have some overlay with anxiety and worry and stress, then this can really benefit and help with young people with asthma. This for me was a shocking fact, and it fits in with having a more sedentary lifestyle and that fear of doing exercise. But if you have asthma and you're a child or a young person, you will average 10 hours more screen time than peers without asthma per week. And this is actually 2017. It feels like yesterday, but actually now that's quite old data, which I suspect may be even more now because I don't think we've made these wider changes about educating people with asthma to really get out there and do more. But we should be. Screen time is associated with worse outcomes all round and it impacts on the other pillars. The more screen time you have, the more blue lights you have, you're more likely to have disturbed sleep. Likewise, the amount of time you spend on TikTok increases the likelihood that you are to vape. We know, and we'll talk about this in a bit, that vaping will impact on asthma as well. So there's lots of other factors. You're also more likely to see things that you shouldn't be seeing at your stage of life if you're a young person watching unfiltered screen time. Swimming. So we often get asked, well, what exercise should we do? And actually, swimming is probably the one that's been studied the most, and it's been shown to be very beneficial. It improves lung function, improves cardiopulmonary fitness. Um, and the worries about chlorination haven't been founded in big studies. Nevertheless, you have to treat every individual, and there will still be some young people that get triggered by having exposure to chlorine. So make sure you don't insist that they go there if that is the case. But it's not one size fits all. So if they don't want to swim, the other studies, the Cochrane reviews, the big systematic reviews have shown that swimming is just the same or not definitely better than other land-based exercises or other exercises. So find something that works for that young person and let them build up on that. Other recommendations we can do. So ensuring the pharmacological treatment is adhered to. Everyone should have a personalized asthma action plan. There's a big move towards adjustable regimes, the maintenance and reliever therapy, MART regime, or the anti-inflammatory reliever air regime. So those ones can be adjusted. And if you've got someone who's deconditioned or not feeling confident, they can have a bit more of that treatment prior to doing exercise to make sure that they feel safe. Warming up and cooling down is irrespective of whether you've got asthma or not, that will help. Cold air can be a trigger for asthmatics. There's a big push towards cold water swimming, which has numerous cardiovascular benefits in older people. If you've got asthma, cold air could be a trigger. So it's worth proceeding with caution. We've also got to bear in mind, we're talking about children, young people, I really want to ensure that they're water safe as well. So making sure that they're supervised appropriately would be really good. Starting with short bursts of activities before you gradually build up, not just going straight in to an endurance activity like the 15-kilometer Tough Mudder I did at the weekend and almost died. Start gradually building up so you can tolerate a bit more and more. And then using your nose. Your nose is incredibly useful. So it warms the air as it comes in, so reducing that cold air trigger, but it also filters out things. So it filters out some of the allergens. Difficult if you're deconditioned not to be panting, breathing through your mouth, but that cold air coming through your mouth unfiltered is more likely to trigger asthma exacerbations than using the nose as it was designed to help. So we're two pillars down. The third pillar is minimizing harmful substances. And the most obvious one associated with asthma is tobacco smoking. And that's not just directly, but that's passive as well. And when I say passive, I don't mean someone standing next to you smoking. I mean someone within the household smokes because they will continue to breathe out carbon monoxide and other harmful substances for 12 hours after they've had a cigarette. And we know that because we measure it in our clinics. We measure the carbon monoxide levels of any adult in the room as well as any young person that smokes to show them what levels they're breathing out. And it's really helpful and useful contact that we're making to try and encourage and do a very brief intervention to try and encourage all the family to look after the young person who's got asthma. We know also that if either you smoke or you're surrounded by someone that smokes, that you're more likely to have an asthma exacerbation. But when you have that asthma exacerbation, the steroids that we treat for that asthma exacerbation are less likely to work, which again is really concerning. Again, this is linked to poverty. You're much more likely to smoke if you come from a household where you're living in deprivation. And we know the Scottish are very good at measuring things. They measured the impact of the smoking ban, and there was a massive drop in asthma exacerbation. So hopefully, with the smoke, tobacco, and vapes bill going through, we will have a whole generation, or the whole of the future generations will never smoke, which would be a great thing. What I don't understand is when vaping is supposed to be a smoking cessation tool, we're not having a smoke and vape free generation where from now on no one can smoke or vape. Vaping is pyramid there because I think we're only seeing the tip of the iceberg of what's happening with vaping. The rates of increase for vaping are much, much faster than they ever were with smoking. Between 2021 and 2023, they tripled in 18 to 24-year-olds from 9% up to 29%. And as a smoking cessation tool, it does help people stop smoking, but at the same sort of level as medication. And at the moment, it's been pushed that swap to stop and all these things where vaping is seen as a harm reduction, and numbers are being plucked out the air. 95% safer than smoking. We don't know that. That number has been retracted now, but was made up. And actually, the overall nicotine use within the UK has gone up. So before vapes, it used to be 28% nicotine consumption. Now it's 35%. So we've increased the amount of nicotine we're using as a country. And yes, we're not just talking about nicotine. There's other stuff involved in tobacco smokes, which we know are harmful, but we don't currently know what's harmful within the vapes. We do know there's heavy metals, there's lead, uranium that get, you know, breathe down right into the depths of your lungs. But we also know from recent studies DNA methylation. So this is to do with epigenetics. In very simple terms, you're born with your genes, you're exposed to stuff which causes DNA methylation, which changes those genes to something else. Epigenetics. We know from smoking studies that smoking causes DNA methylation to certain genes that go on to cause different problems, like cancer. We know that. They've done studies that looked at e-cigarettes and smoking and saw that a large chunk overlapped. There was DNA methylation changes, epigenetic changes that were the same for smoking tobacco and smoking e-cigarettes. That's scary. But what's more scary is there was a huge chunk of DNA methylation changes, a huge chunk of epigenetic changes that are happening when you're exposed to e-cigarettes that we have no idea what that's going to cause. And we won't know for some time. What we do know is that we don't know. So we shouldn't be encouraging vaping in children and young people. Using it to get off cigarettes is fine. I say fine, but it's something that is probably going to be better than smoking, but we just don't know by how much. And so we really need to be advocating to try and get rid of vaping for young people. And how it's designed is not for 50, 60-year-olds trying to quit smoking. The flavors are not there for that. They're to entice young people. And I think just like doctors promoted smoking back in the day, I think we will look back and see maybe this was a bit of a public health disaster, but time will tell. Caffeine. Caffeine's a natural stimulant. I get through a fair amount of caffeine every morning, and it's been shown to improve lung function. So it improves for about 4 hours with bronchodilator effects. But you do need 5 to 10 milligrams per kilogram in body weight of caffeine. So that's quite a lot because one cup of coffee contains 150 milligrams. So if you are a 75 kilo person, that means that would be about 2 milligrams per kilogram. So you need between 3 and 5 cups of coffee to get any bronchodilator effects for an average size male human. If you're having 3 to 5 cups of coffee within a 4 hour period, I'll remind you of that, then you're likely to get some side effects. And in children, that's likely to be an increased heart rate and definite impacts on sleep. So caffeine should not be used as a bronchodilator effect. And ideally, the benefits do not get outweighed by the risks. And the risks impacting on sleep are significant, as we'll come to later. I like to keep an open mind, and lots of families want to talk about complementary medicines. I'm all for complementary medicines as long as they don't do any harm, rather than alternative medicines. And lots of our traditional medicines that we use in pharmacology now came from these herbal medicines in the past. And there is some evidence that there's benefits of these. The three that stand out from the reviews and the literature are Boswellia, Maymendong Tang, and Pycnogenol. So it's one that people might mention, is it okay to have? And none of these interact with any of the traditional asthma treatments as part of the big guidelines. But there's currently insufficient evidence for NICE guidelines or the BTS guidelines to say this is what should be given. It's not going to cause any harm at the moment, and ideally we just need more research to explore this in a bit more detail. Just want to run through what happens with oxidative stress and how this is balanced out by lifestyle factors. So you get oxidative stress by the balance of reactive oxygen species and antioxidant defenses. If there's more reactive oxygen species and less antioxidant defenses, you get oxidative stress, you get that inflammation. That can cause ongoing problems, and it can be from environmental insults that either damage the antioxidant defenses or boost reactive oxygen species. We know that stress can do that as well. We know that ultra processed foods can do that. We know that pollution and lots of other things can do that, and dietary things can happen. So in terms of balancing this out, that's what we need to be really clear. We need to try not to increase the reactive oxygen species, try and keep these as low as possible, and try and boost up the antioxidant deficient antioxidants to reduce oxidative stress, reduce inflammation as much as possible. We know that if you've got chronic reactive oxygen species production, this changes the way the beta receptors signal, which means that if you've got that chronic inflammation, for example, if you're obese or if you're living in a highly polluted area, then when you try to give your salbutamol, it's not going to work in the same way as if you didn't have this. So it's really important that that's the mechanism involved, and we can address these factors using lifestyle. Very sadly, air pollution does kill asthmatics. And in London on South Circular, there was Ella, um, who died now, I think, over 10 years ago, who it's so sad that she was exposed to these toxic levels of air pollution. And she was the first person to have air pollution listed as a cause of death on her death certificate. And there are no links between air pollution, increased asthma severity. If you're pregnant and you live where there's pollution, you're more likely to have your offspring develop asthma. And diesel in particular is associated with increased airway inflammation and oxidative stress. So we need more constraints, more rules put into place to ensure that this doesn't progress. We also cause harm. So montelukast, to be clear, is a fantastic drug when it works. It's a leukotriene receptor antagonist. It reduces inflammation within the airway. It helps for allergic type asthma. It also improves symptoms of obstructive sleep apnea. Fantastic when it works. It can cause bad dreams, disturbed sleep, night terrors. And what's really worrying is that in older children, it can significantly impact their mood and behavior, with some case of suicide, which is why it's really gone out of fashion a bit. And it's something that whenever we consider starting, you have to have these open conversations with the young people in the family to watch out for it. It has been shown that when you stop montelukast, those side effects completely resolve. So as soon as they're recognized, it should be stopped. But it doesn't happen in the majority of patients, but it is a well-recognized side effect. So it's something to watch out for. We use Medicines for Children information leaflets because they're very comprehensive and good. Steroids used to treat asthma exacerbations, reduced inflammation can be really helpful. There's a lot of debate about preschoolers and steroids, and there was a wheeze and steroids in preschooler study called the WASP study, which is the code name, that looked, and steroids help if they're severe, so if they need oxygen for the first 24 hours. As soon as they're not in oxygen, they don't need any more steroids. There's no more benefits. What previous studies, now about 20, 30 years old, showed is if you give steroids at a dose of 1 milligram per kilogram of prednisolone to a child under the age of 5, 2 or more courses in a year, they are twice as likely to fracture their humerus in the next year. Steroids, oral steroids, have more significant side effects than inhaled steroids, and they can thin the bones and cause lots of problems. So we should be reserving steroids in preschoolers unless they've got diagnosed severe asthma and it's part of their asthma action plan for the cases that require hospital admission. They should not be given in primary care unless it's part of their asthma action plan. And what else can we do about controlling other things? So humidity, dampness can cause mold. Mold can trigger wheeze and respiratory problems. As a general rule, if you wipe off the mold to the point you can't see it, it shouldn't be impacting on the breathing. But humidity can also breed other allergens as well, such as house dust mites. Never ever look at a cuddly toy under a microscope. You'll be shocked, but that's where they live, particularly with children. Lots of cuddly toys around their head when they're sleeping with house dust mites causing an allergic response, making them cough all night long. You'd think washing would get rid of the house dust mite. You actually need to freeze the cuddly toys for a minimum of 12 hours to get rid of the house dust mites. Pests, and here I'm talking about cockroaches, bird poo, more in developing countries, but if you're living in extreme poverty, this may be a factor. So trying to minimize that as much as possible. And I've spoken about tobacco and vapes already, probably drummed that into you enough. And air purifiers, again, there's not enough evidence to say the NHS is going to pay for this, but actually it can purify the air at home. Healthy relationships, a fourth pillar. So adverse childhood experiences, they're defined as anything bad that happens in your childhood. And it's normally some form of abuse, household dysfunction, or exposure to something really nasty. I think over time, we're going to see adverse childhood experiences defined as exposure to horrible things that you can see on social media. There's lots of kids who are seeing things like beheadings or porn at an early age that can then become distressing and worsen health outcomes. And it's dose dependent. So the more adverse childhood experiences a child experiences, the more likely they are to have worse health outcomes. um, so we need to recognize these and try and prevent them from progressing and do what we can, again, associated with poverty. We need social connections and having a social support, so a supportive family around practically and emotionally supports that child with asthma makes them feel confident, and will also ensure that they take their medication. Being isolated, you're more likely to have poor asthma management, less likely to adhere with what's prescribed, and have more exacerbations of the symptoms. So we use our youth workers a lot to encourage these connections, to try and build in and connect people into whatever's available in your local area to improve well-being. And potentially with sports and team sports, there's huge opportunities to improve different pillars in the same action. Parents obviously impact upon children quite significantly, and the parenting styles will impact on asthma outcomes. So we know that very controlling parents will ensure their children take all their medication, but they may not wish for them to be involved in physical activities or exercises. So we really need to work with parents and the whole family to educate them on the benefits of what works in terms of lifestyle modifications to try and improve things as much as possible. And you need to adjust this because, again, we've spoken about how poverty is associated with more asthma and worse asthma outcomes. So catering the health literacy to the individual families to make sure that they fully understand what we're talking to them about, and providing written and verbal information that aligns with that. But we know that active involvement from parents improves their asthma management, but also builds up their confidence of what they can do with better outcomes overall. If parents are stressed, that has been shown in numerous studies to worsen asthma care and hinders effective management. We also know, I've mentioned about ACEs, but if you live somewhere where there's community violence, you have worse asthma symptoms, which highlights environmental stresses. But again, you've got lots of confounding factors of living in poverty. And if you've got psychosocial stress, again, those salbutamol, the bronchodilator inhalers, may not help as well as they would do if you don't have stress. And that may be the chronic reactive oxygen species that you get from psychological impact that then augments the beta cell signaling pathway. So stress management and pharmacological management together is going to be important in managing this. So yeah, high crime rates and weak relationships worsen asthma symptoms. Lots of studies prove that. Schools are really important. There's a school specialist interest group. So if you're keen to get involved in that, get in touch with Dan Newman. It's a very active group, much more active than the pediatric one currently, and they've got some fantastic resources that they're developing. We've developed asthma-friendly schools as part of improving asthma care across the country, so that schools understand and recognise when a child's got asthma, how they can encourage them to be more active in a safe way. But also recognise if that child doesn't have well-controlled asthma, to signpost and support them, as well as being confident in dealing with any life-threatening emergencies. It's great to avoid isolating children by saying, right, you've got asthma, you need to sit out of this PE session. They become socially isolated, they become stigmatized. That shouldn't be the case. We shouldn't be able to recognise by looking at a PE group which one's got asthma. They should be able to participate fully. The NHS 10-year plan is very much going to be focused on this, which is really great. So we're going to see more integrated care models, more working with families, neighbourhood teams. There's a lot that's going to be moving in this direction. So we need to really, really encourage and support this and think of the best models of care to make it work for our local systems. So we need healthy relationships and health. They go hand in hand. You're treating the whole family, not just the individual child. Adverse childhood experiences associated with poverty, trying to recognize them and get changes in place to prevent that from happening. We need huge societal changes to prevent poverty and widening health inequalities that are very much linked to these ACEs. We need social connections. We need to utilize professionals like youth workers, work with schools to try and ensure that children and young people with asthma have those social connections and support. And then it's family-based approach with that holistic approach to health overall. Right, 2 more pillars to go with 17 minutes. I'm cracking through it. So mental health goes hand in hand with asthma to the point that it used to be called asthma nervosa. It's not called that anymore, but there are still significant links. We know that children with asthma have more behavioral problems than peers without asthma. That's scientifically proven. And it's not just those on Montelukast. It's not that just those who have been given oral steroids. It's very much linked. We also know that internalizing disorders, the big two being anxiety and depression, is very much linked to asthma severity. There's also a functional overlap. So if you have vocal cord dysfunction or dysfunctional breathing, that again makes it really tricky to manage, because what you really want to do is focus on breathing techniques rather than pumping them full of salbutamol, which may increase their anxiety because it's pushing their heart rate up. So trying to balance the individualized treatment can be really tricky. We know asthma is the biggest cause in terms of chronic conditions of missing school days. That can again lead to these vicious cycles of social isolation. And again, with internalizing disorders, can make things worse. And what's interesting is if you've got an internalizing disorder like anxiety and depression and you've got asthma, you're more likely to rely on your reliever medication, the blue salbutamol inhaler. And the Sabina study has shown that the more salbutamol you use, the more likely you are to die. So we shouldn't be, it should be flagged up that if you're using too much of your salbutamol, your blue inhaler, you need to address what your regular treatment is. And interestingly, the patients who have both of these conditions use less of their preventative treatments, which unsurprisingly results in worse lung function and more emergency setting presentations. Again, we can't just say, well, this is all asthma, let's focus on the asthma. When there's internalizing disorders, we need to work on an individualized basis and focus on the whole holistic person to try and improve their overall asthma care, but really focusing on the preventative side of things to try and get their asthma under control, which again may break one of the vicious cycles that's perpetuating the problems. Stress management is really good. So there's deep breathing exercises. You can do box breathing. My daughter loves this, where you breathe for a certain amount of time, hold it, breathe out, and then hold it. And you can work your way around the square. With asthmatics, they can do this during exacerbations. They probably need to start on somewhere brief, like 2 seconds for each one of those sides of the square, and gradually increase it. Mindfulness and relaxation techniques. Often when I mention this in clinic, I get an eye roll, particularly from the teenagers. But actually, when you explain that it's not just doing some scripted mindful technique, it could be anything from relaxing in a way that works for them. It could be a warm bath, it could be lavender, it could be some form of meditation, or it could be playing a computer game that's known to be relaxing. So Animal Crossing on Nintendo Switch, there's studies coming up that shows that soothes them, that alleviates stress marks and things like that. So there are things that are good for people on their screens. Screens aren't completely bad, but ideally, if we can get them up and about, that would be better. Yoga is becoming more popular in terms of with asthma. There's more and more studies. That's my three children there practicing. We do couples yoga, myself and my wife, and it does help. It's been shown to be beneficial in asthma. So meditation helps clear the mind and reduce anxiety, part of yoga. There's aspects of that. It improves quality of life in people with asthma. And there's small studies coming up with children, young people, but you get improved lung function. You get reduced symptoms and the need for medication. And you have more days where you just don't have any symptoms at all, which is the ideal. That's what we want for every asthmatic. Meditation as well. Enhanced asthma-related quality of life, lower stress. That's adult studies. And again, meditation, you need to picture the right level, and it won't be for everyone. Massage therapy. I'm very happy to volunteer for any of these studies, but massage therapy has again been shown to be beneficial for children, young people with asthma. So it improves the inspiratory and expiratory muscles, benefits children, optimize ventilation. It's easily implemented at home. And if you get family members to do it, again, it builds on that other pillar of that social connection and the family bonding. You see less stress levels, so reduced cortisol levels. It's been enhancing asthma treatment, so significant effectiveness. So again, a benefit for the pharmacological side of things by doing lifestyle modifications. And it's been shown that it improves lung function, as well as reduced anxiety. So all round really good. Manual therapy, so focusing on mobilizing the ribs and thoracic cage. You'd think that might help even more with asthma, but actually, and we have to be open about this, it hasn't shown any benefit in adults or children with asthma. However, it doesn't cause any harm, so it's not something that should be boo-booed or dismissed. If families want to do it, that's absolutely fine. But for now, we can't advocate and say it's definitely going to help. Acupuncture. I love a bit of acupuncture, and it's snuck into some of the other national guidelines. So it's now part of the migraine guidelines from NICE, which is fantastic, and it's been shown to benefit in adults from this systematic review. There's mixed results in children. So there's 7 studies that have happened. 3 showed no benefit to quality of life improvement. 2 did show improved lung function, and 1 showed reduced anxiety levels. The methods they used in the various studies was very mixed. So it's difficult to draw wholesale conclusions. But actually, with some benefit, it's worth exploring, particularly if you've got someone who's quite resistant or refractory to treatment and want to try anything. Sleep. So we're on the final pillar now, and sleep and asthma go hand in hand because one of the most common symptoms of asthma is nocturnal cough, which disturbs sleep. We know sleep is really important for overall health, but also asthma control. We know that your body fights infection. And if you don't sleep effectively, which is funny because sleep in hospital is awful, then you have a weakened immune response. You don't fight infections well if your sleep is broken and disturbed. There's also overlapping conditions such as obstructive sleep apnea and other sleep related breathing disorders. So, trying to get sleep habits as good as possible, as early as possible, is really important. We also know that if you don't sleep for long enough or good enough, then actually you gain weight quicker. So, you have a higher BMI if you've got poor sleep. Which is interlinked. And again, the schools, SIG has produced some resources where you can go into schools and teach about optimal sleep, which is really helpful. Parasomnias affect 2% of the population, 2% of children, but much more in asthmatic children. I've mentioned about Montelukast. Once you stop it, that goes away. Thinking holistically about children with asthma, though, something that won't often get asked is, do they wet the bed at night? And actually, this can be the biggest problematic thing for a 10-year-old, is that they're wetting the bed more than twice as much as someone who doesn't have asthma. The exact mechanisms and the reasons aren't known about, and you won't know unless you ask, because 10-year-olds won't willingly offer that information. But that potentially could create social isolation. They might not be wanting to go to the sleepovers that they've been invited to. It might create problems with the family who have to change the sheets in the middle of the night. There's all sorts of factors that come into play that, again, is a reminder that holistically we need to treat this child and focus on what matters to them to ensure that their whole lifestyle is augmented and not just their lungs. Movement disorders. So this is more adult folks. So I won't go into too much detail about this, but there's an increase association with restless leg syndrome, periodic limb movements, obstructive sleep apnea, and therefore with asthma. And so all of these need to be addressed and can be augmented. Magnesium is probably the best supplement for dealing with all of this because magnesium helps with muscle relaxation. It helps with all of the restless leg syndrome, periodic limb movements, and it helps with asthma as well. So magnesium and doing lots of exercise during the day is likely to help with this. Again, you've got other circadian disorders and asthma interlinked. So you see that circadian rhythm change with diurnal rhythms in asthma patients, which is well known. That does mean, and I'm not sure you can group everyone exactly as a lark or an owl, but owls, so people who prefer the evenings, are much more likely to wheeze, 80%, 85% higher risk of wheezing, and almost threefold higher chance of developing asthma. So if you're an early bird like me, you're safe. But actually, if you're an owl and you prefer the evenings and the nighttime, then you've got an increased risk of asthma. And there's a huge coexistence of sleep-related breathing disorder and asthma, and that in adults will increase morbidity, which is not good. So summarizing asthma and sleep problems, they're interlinked. So you get asthma and sleep-related breathing disorders that have shared inflammatory mechanisms, which is where the treatments like leukotriene receptor antagonists, Montelukast, potentially could help both. We know that there's inflammation involved in it, and there's mixed risk factors. So there's some you can change and some you can't, but obesity, gastroesophageal reflux should be optimized and treated as well. You can't change the fact if you're African American, but that's an increased risk factor for both as well. Things have changed as well. So it used to be down to just anatomical problems, but with obesity causing more obstructive sleep apnea, again, it's more like adult pictures causing those problems. And then rhinitis. So asthma is predominantly an allergic condition. So they might have allergic rhinitis symptoms, which may affect them worse at night. And asthma is a spectrum. So there's not one condition. It's a whole range that we don't have a precision medicine yet to really focus, but trying to address all aspects of that individual patient is really important. So summarize. I've gone through the 6 pillars and how they interplay and interact with asthma. We've spoken about healthy eating and how poverty plays a part in not being able to afford to eat the rainbow, the 30+ plant points, Mediterranean diet, trying to address that microbiome and exciting potential studies looking at pre and probiotics. Physical activity, people with asthma are scared to do it, but we need to be encouraging them to do it in a safe, supported way because it will improve things overall. Making sure that we avoid smoking, we avoid vaping and other harmful substances. We work with society to minimize pollution as much as possible and we'd be open to complementary medicines rather than alternative medicines. Healthy relationships, trying to make sure that we avoid adverse childhood events and experiences and work with families, not just an individual, to improve the overall family setup and care of that child. Mental well-being, so it used to be asthma nervosa. It is highly associated with stress, worry, anxiety, and again needs that holistic approach to tackle all of it together. And sleep's so important with lots of overlap again, which will help your body fight infections and also improve your asthma control overall. So lots of stuff. None of the pillars stand alone by themselves. They all interlink and intertwine. And I think I've left a few minutes for some questions. So I'll stop sharing my
Seb,
screen now.
Seb, thank you. That was phenomenal. That was amazing. It was like a one-stop shop of everything about asthma. I don't think we've got time for questions. I'm so sorry because we've run over. But what I would ask, Seb, is would it be all right if anybody has any questions to email office@bslm.org.uk and we can send them over to you? Would that be all right?
Absolutely
And
fine. Yep.
sincere apologies from our side because we had some technical difficulties. We started a little bit later, so we haven't had got to, because we started later. We've ended up finishing and didn't have time for questions. So I'm really sorry about that. But I think there is one question about your resources, and can we share your slides? I think people
Absolutely
wanted
fine.
to.
Yes.
That would be amazing.
Yep.
So thank you so much, Seb. Thank you for giving up your time and a superb presentation.
Thank you
Much
very much.
appreciated. And if you would like to join the SIG, let us know as well through that email address. Thank you, everyone. Good to see you.